Welcome, deep divers. Today, we're really getting into something we all deal with, but it often feels surprisingly complicated. The world of sleep.
Mm.
We've all had those nights tossing and turning or, fighting off that afternoon slump. But what happens when those little struggles become, well, persistent problems? Big puzzle.
Exactly. And that's what we're tackling today.
Our mission here is to kind of cut through the noise around common sleep conditions. We want to give you the tools to tell them apart, understand what makes them tick, and crucially spot those subtle differences. Our guide calls them splitters, which I think is a great term.
It really is.
Our source material for this deep dive is this fantastic clinical study guide. It's like a field manual, really, designed to pinpoint these sleep-wake issues. It focuses on where they overlap, which is confusing, but more importantly, how you find those key clues.
Think of this as your shortcut to becoming a bit of a sleep disorder detective. We're aiming to arm you with the insights to quickly sort through these common disorders, get their core features, and, spot those tiny clues that often fool even experienced folks. We're digging for the nuggets.
Let's jump right in. First, big category, excessive daytime sleepiness, EDS.
Super common complaint, right?
Right.
And a lot of different things can cause it. That's where it gets messy.
It absolutely does. But the material highlights these prototype vignettes, little stories that give you clear paths if you know what signs to look for.
And it's often the really specific clues that matter most, isn't it?
Totally. Take our first one, narcolepsy type 1. The classic image is that laugh then collapse college student.
Right.
So picture someone who suddenly loses muscle tone, maybe their knees buckle when they get excited or laugh hard. That symptom, cataplexy, that's the big one, the fingerprint.
Another key thing, naps actually make them feel completely refreshed, like properly revived, even if just for a bit. Diagnostically, cataplexy is huge, often backed up by SOAR.
Sleep onset REM periods.
Exactly. On an MSLT, that's the multiple sleep latency test, means they pop into REM sleep way too fast during daytime naps. And sometimes, low levels of a brain chemical orexin are involved too.
Okay, here's where it gets tricky, right? The pitfalls. Our guide points out a classic one. The patient says they snore sometimes.
Mm-hmm.
That doesn't automatically mean it's obstructive sleep apnea, especially if cataplexy is there.
Right, absolutely. Snoring without someone actually seeing them stop breathing or without major daytime issues from the snoring, it's just not enough to call it OSA if you've got clear cataplexy. Cataplexy trumps it, diagnostically speaking.
Got it. So what's next on the list for EDS?
Let's talk about idiopathic hypersomnolence, IH. Picture the foggy commuter. This is someone sleeping like 10 hours or more consistently every night.
Wow, 10 hours.
Yeah, and they take these long naps that just don't help. They don't feel refreshed. And waking up, it's a real battle. That sleep inertia.
That groggy feeling you just can't shake.
Exactly. That profound difficulty getting your brain fully online. So the keys here are that long sleep time over 9 hours usually, plus that really persistent sleep inertia.
And here's another trap the guide mentions, automatic behavior while driving, like missing your exit without realizing it.
Right. That happens in narcolepsy too.
Ah, okay, so you see that, but it could be IH or narcolepsy.
Precisely. So how do you split them? In IH, you don't have cataplexy, and you typically don't see those early SOREMs on the MSLT. It's about what's missing.
Interesting. Okay, what about the really common one, obstructive sleep apnea, OSA?
OSA. The classic picture here is, say, a middle-aged man, maybe BMI 35, snores loudly, wakes up with headaches, might have high blood pressure.
The key evidence.
Witnessed apnea, someone actually saw them stop breathing. Or an AHI, that's the apnea-hypopnea index, of 15 or more on a full sleep study, a polysomnography or PSG.
It's amazing how they can try to trick you, though. The guide says EDS in OSA can look a lot like narcolepsy.
Oh, definitely.
And a test question, or maybe even a real case, might not mention the obvious snoring, but they'll slip in hypertension and obesity.
Right. And if you see those two together in someone with EDS, even without the snoring mentioned, that should make you think OSA pretty strongly. It's a big clue.
Good tip. What's the last one for EDS?
Last one here is circadian misalignment. Think of a medical resident on night float. They just can't stay awake during the day, but you do the sleep studies PSG, MSLT, and they're totally normal.
So it's not the sleep itself, it's the timing.
Exactly. It's usually straightforward sleep deprivation because of the schedule, or classic shift work disorder. The fix isn't stimulants, it's fixing the schedule.
And the big clue against other things here is those normal sleep studies.
Yep. Normal PSG and MSLT points you away from narcolepsy or IH right away. The basic sleep machinery is fine, it's just running at the wrong time.
Okay, so let's quickly recap that EDS investigation, like a checklist.
Yeah, a rapid algorithm. Step 1, is there cataplexy? Think narcolepsy. Step 2, long sleep plus that heavy sleep inertia. Points to IH.
Okay.
Step 3, snoring, obesity, hypertension. Look towards OSA. Step 4, rotating shifts or consistently getting less than, say, 6 hours sleep. Consider sleep deprivation or a circadian issue.
Great framework. So we've navigated the maze of being too sleepy during the day. Now let's investigate something equally fascinating, unusual movements during sleep.
Ah, yes, the things that go bump or punch in the night.
Right, and here the key seems to be distinguishing between stuff the sleeper forgets entirely and things they remember really vividly.
This is where those splitters we mentioned are absolutely crucial. We need to differentiate between NREM parasomnias, REM sleep behavior disorder, RBD, and nightmare disorder.
Okay, break it down for us. How do we tell them apart?
Let's use the guide splitters. First up, age peak. NREM stuff like sleepwalking or night terrors, mostly kids, maybe 5 to 12 years old.
Right.
RBD, typically men over 50. Nightmare disorder, more teens and adults, often more females than males.
Okay, age is one clue. What else?
Sleep stage and timing. NREM parasomnias happen in N3 sleep, that deep sleep, usually in the first third of the night. It's like an incomplete wake-up, they're confused, amnestic.
Got it.
RBD happens during REM sleep, usually the second half of the night. The key here is REM without atonia. Their muscles aren't paralyzed like they should be in REM, so they physically act out dreams.
Okay, and nightmares.
Also REM sleep, but often later in the night. But the big difference is vivid recall on waking.
Let's talk about the core behavior then.
Yeah.
What do they actually do?
NREM parasomnias, think sleepwalking, maybe sleep terrors. Eyes might be open, they can seem distressed, maybe sweaty, heart racing, that autonomic storm.
Yeah.
But simple, sometimes complex, but usually not dream-related actions.
Okay, RBD.
That's the complex dream enactment. Punching, kicking, yelling, flailing. Sometimes they injure themselves or their partner. It looks like they're fighting something in a dream.
Yeah, and nightmare disorder.
Primarily intense dream fright. Maybe some mumbling, slight movements, but not that complex, violent, physical activity you see in RBD.
And the final splitter.
Yeah.
Awareness and recall. This seems critical.
Hugely critical. NREM parasomnia. If you wake them, they're confused, disoriented, and have no memory, or maybe just a fragment.
Okay.
RBD. Wake them up, and they're often immediately alert, oriented, but crucially, at least in the classic vignette, they don't recall a specific dream matching the violent actions they were just doing. They might know they were active, but not the why.
That's a key distinction
Right.
compared to nightmares.
Right. With nightmare disorder, they wake up, they're oriented, and they have full, detailed recall of the scary dream content.
Okay, that recall difference is huge. The guide calls these shelf favorite tricks. Any examples?
Definitely. Okay, you see an adult who starts, say, sleep eating after starting a Z drug like zolpidem.
Uh-huh.
That points to NRM parasomnia. The drug kind of disinhibits them during that deep sleep. Another big one. Patient has PTSD and they're on an SSRI antidepressant. And they start having violent sleep behaviors. That often points to RBD because SSRIs can actually worsen RBD or bring it out.
Wow, okay. So you really need to distinguish that RBD motor activity from just nightmares, which are mostly mental with little movement.
Exactly. That's a classic test setup. Know the difference. RBD is vocal and motor. Nightmares are mostly just the recalled fear.
So what about treatments for these?
First line is always safety. For NREM parasomnia, make the environment safe, locks on doors, clear floors. Meds like low-dose benzos are really only if it's severe or dangerous.
And for RBD?
Clonazepam is usually the go-to, a small dose at bedtime. Melatonin can be an option too, especially if there's a fall risk with clonazepam. Again, safety is key, padding the bed area maybe.
Makes sense. Nightmares.
Imagery rehearsal therapy, IRT, is a primary behavioral approach. Basically, you mentally rewrite the nightmare with a better ending and practice that version while awake. If PTSD is driving it, the medication prazosin can sometimes help.
Okay, super helpful. Let's switch gears again. We've done sleepiness, we've done movements. What about problems with the timing of sleep? The clock problems.
Right. This is different from just not being able to sleep well in general.
Right.
This is about when you sleep and wake. We need to contrast delayed sleep phase disorder, DSPD, and advanced sleep phase disorder, ASPD, with plain old primary insomnia.
Okay, lay them out for us. DSPD.
DSPD, think night owl. The classic case is a teenager who just cannot fall asleep before, say, 2 or 3 a.m., no matter how early they go to bed. Then they struggle to wake up for school.
But on weekends?
Exactly. On weekends or holidays, they sleep in until noon, get a full night's sleep, and feel totally refreshed. Their clock is just shifted late. They can't easily advance it.
Okay, ASPD.
The opposite. Think early bird. Often an older adult. They get sleepy really early, maybe 7 p.m., go to bed, and then boom, they're wide awake at 3 or 4 a.m. and can't get back to sleep.
But they feel okay.
Often, yes. If they accept that schedule, they might feel fine during the day. Their clock is shifted early and they can't easily delay it.
Gotcha. And how does primary insomnia differ from these clock problems?
Primary insomnia isn't about the timing shift, fundamentally. It's about difficulty falling asleep, staying asleep, or non-restorative sleep despite having adequate opportunity. Think of the middle-aged person awake till 2 a.m., feels awful the next day, and even on vacation when they could sleep in, they still sleep poorly. It's a quality-quantity issue, not a phase issue.
Those descriptions are really clear. So what are the hard diagnostic clues, the pearls?
Actigraphy is helpful. That's the wrist device tracking sleep. For DSPD, it'll show that sleep period is delayed by more than 2 hours compared to what's desired or conventional.
And ASPD.
The opposite sleep period advanced by more than 2 hours. For primary insomnia, the key criteria are duration. It has to happen at least 3 nights a week for at least 3 months, and it causes distress or impairment despite adequate opportunity for sleep.
And the guide mentions an exam trap for DSPD.
A really common one. The vignette might start with difficulty falling asleep. Your first thought might be insomnia, but then it adds that critical detail. On weekends, they sleep late, get normal sleep duration, and feel refreshed. That tells you it's circadian. The sleep itself is fine, just shifted.
Uh-huh. And for ASPD, if someone wakes early but isn't bothered by it.
Then it doesn't necessarily need treatment. If they
Yeah.
feel fine, function well, maybe just have an extra coffee, it's not a disorder unless it's causing them problems or distress.
That makes sense. And a really important point you made earlier, if the story mentions depression or ADHD meds or alcohol.
Always look for secondary insomnia first. Those things can massively disrupt sleep. Don't jump to primary insomnia until you've ruled out other causes or contributing factors.
Crucial. Okay, treatments for these timing issues versus insomnia.
For DSTD, the late problem. You need a strict, fixed wake time, even on weekends. Bright light therapy right upon waking helps reset the clock. And low-dose melatonin taken carefully in the evening, hours before the desired bedtime, can help advance the rhythm.
And for ASPD, the early prop.
Evening bright light therapy can help delay the clock. Chronotherapy, which involves systematically shifting sleep times, is sometimes used but can be complex.
And primary insomnia.
First line is always CBTI, cognitive behavioral therapy for insomnia. It addresses the thoughts and behaviors that perpetuate poor sleep. Medications, hypnotics, are definitely second line.
Okay, great distinctions. Let's move to another set of symptoms. Leg discomfort and those jerky movements at night.
Right. These can be really disruptive. We need to differentiate restless leg syndrome, RLS, periodic limb movement disorder, PLMND, and medication-induced akathisia.
Okay, RLS first. What's the defining feature?
The absolute core of RLS is an urge to move the legs. It's often accompanied by unpleasant sensations,
Yeah.
creepy crawly, itchy, burning. It gets worse during rest, typically in the evening or at night.
Key thing?
It gets better with movement. Getting up and walking around provides relief. Also, check ferritin levels. Low iron is often linked. The buzzword phrase is definitely creeping, crawling calves at bedtime.
Got it. PLMD, how is that different?
With PLMD, the patient often has no idea it's happening. It's usually the bed partner complaining.
Ah, the bruised bed partner.
Exactly. The sleep study, the PSG, shows these rhythmic kicks or jerks usually every 20 to 40 seconds during sleep. The patient isn't feeling an urge like in RLS. It's involuntary movements during sleep.
Okay. And akathisia.
Akathisia is different again. It's an inner restlessness, a feeling of needing to be constantly moving, but it's usually present throughout the day, not just at night or rest. And importantly, it's often linked to starting or changing doses of certain medications, especially antipsychotics like haloperidol. It's not really circadian.
And the guide points out a potential pitfall here, distinguishing RLS from other things.
Yeah, sometimes test questions might throw in options like akathisia or just nighttime leg cramps. But that specific combination, the urge to move that's worse at rest, plus the relief with movement that's the signature of RLS, that combo clinches it.
Very clear. And a crucial treatment point for RLS.
Super important. If the case mentions a ferritin level below 75 ngml, iron replacement first. Even if other RLS meds are listed as options, treat the underlying iron deficiency before jumping to dopamine agonists or other symptomatic treatments.
Excellent point.
Yeah.
Okay, we've dissected a lot of individual disorders. Now let's try putting it all together. Apply this to some real-world type scenarios.
Perfect. Let's use the cases from the study guide. First, Mr. Everett. He's a 65-year-old veteran, chronic PTSD. His wife says he thrashes, punches, yells in his sleep. So much so, she's moved to another room. He doesn't recall any vivid dreams associated with these episodes, and he's taking sertraline, an SSRI.
All right, listeners, let's play detective. What are the key clues here? Older man, violent actions during sleep, no dream recall of those actions,
Yeah.
PTSD history, and he's on an SSRI. What's jumping out?
Given all that, the diagnosis screaming out is REM sleep behavior disorder, RBD.
Why RBD specifically?
Well, it fits perfectly. The age, the violent dream enactment behavior, the lack of specific dream recall matching the actions, the known association with PTSD, and critically the SSRI use, which can trigger or worsen RBD.
Right. It's not nightmare disorder
Because he doesn't have that vivid recall of the dream content upon waking from the episode.
and not NRM parasomnia like sleepwalking.
Unlikely given his age, that's mostly kids. And the type of movement is more complex and seemingly goal-directed, like acting out a dream, not just walking or sitting up confused. Plus, the timing often fits REM sleep better later in the night.
And a treatment.
Confirms our thinking, clonazepam is indeed first line for managing RBD symptoms and keeping everyone safe.
Okay, great case. Let's try another one. Miss in Hinojosa. She's 18, works early at a daycare, can't fall asleep until maybe 3 hours after she goes to bed. Waking up is torture. Needs energy drinks. But on weekends, she sleeps in 8-9 hours and feels totally refreshed afterwards.
Okay, following the clues again. Delayed sleep onset.
Yep.
Major trouble waking for an early start. Clear functional impairment needing caffeine. But crucially, that catch-up sleep on weekends is restorative. She feels good after it.
So what does that point to?
This pattern is classic for circadian rhythm sleep-wake disorder, delayed sleep phase type DSPD.
Well, why not insomnia?
Because when her schedule allows it, she sleeps well and feels refreshed. Her sleep quality itself isn't the core issue, it's the timing relative to her required schedule.
Not IH.
No, she doesn't have those long, unrefreshing naps or excessive sleep duration when she is on her weekend schedule. She feels refreshed after 8-9 hours.
And no signs of OSA given.
Nope. Nothing in the description points that way. It's purely a timing mismatch.
So if it's a timing problem, what's the right first step for her? Why not just give her a sleeping pill?
Because that just masks the problem. The best approach is education on sleep hygiene, plus those phase-advancing measures we talked about.
Yeah.
Meaning a super consistent wake-up time, 7 days a week, morning bright light exposure right away, avoiding stimulating things in the evening, maybe timed low-dose melatonin in the evening, but with education on how and when to use it as part of shifting her clock. You have to treat the underlying circadian misalignment, not just knock her out temporarily.
That makes perfect sense. Retrain the clock.
Exactly. Which brings us nicely to that exam day booby traps checklist from the guide. These are the absolute must-knows to avoid common errors.
Hit us with them.
Okay. 1. Snoring alone is not OSA unless you have the daytime impairment or the AHI confirmation. Don't assume.
Got it.
2. SORMs alone don't mean narcolepsy. You need cataplexy or that very short sleep latency on the MSLT. SORMs can pop up from sleep debt, med withdrawal, OSA, even DSPD.
Okay, crucial nuance.
3. Remember, SSRIs and NRIs can trigger or worsen RBD. Always check the meds list with weird sleep behaviors.
Like what?
4. Benzo and alcohol withdrawal can cause nasty rebound nightmares. Get that substance timeline. 5. For RLS, if ferritin is under 75, treat with iron first. Don't skip that step.
Iron first. Check.
And finally, 6. Sleep hygiene by itself won't fix a phase disorder like DSPD or ASPD. You need the timed interventions, fixed wake time, light therapy, maybe melatonin to actually shift the clock.
Fantastic checklist. Okay, wrapping up this deep dive, what are the absolute core principles we should take away?
I'd say, first, always match the phenotype. Is it a timing issue, a sleep maintenance issue, or a behavior issue? Define the type of problem before slapping on a label like insomnia.
Okay.
Second, prioritize safety. If there's substance misuse impacting sleep or dangerous behaviors like NRBD, address that first before a standard workup.
Makes sense.
And third, for those chronic clock problems and primary insomnia, remember the mantra: behavior and environment first, CBTI, light therapy, schedule adjustments. Those come before pills.
Excellent summary. Behavior first.
Right. And maybe a final thought to leave you with, thinking about how we just dissected these sleep disorders, looking for those subtle splitters and avoiding the traps. How could applying that same kind of careful observation, looking beyond the obvious surface symptoms, questioning assumptions, seeking out those small but decisive details, how could that change how you approach other complex problems in your life, whether it's health or work or even relationships? Just something to consider.